so much for joining us this evening, giving up your Wednesday night. We really appreciate it. As you all know, you're here tonight to have a bit of a chat about diabetes. Now, I'm going to hazard a bit of a guess that probably the majority of you are here because to some degree you're not that keen on diabetes. And I get it, it's a complex disease. There's no one size fits all. It's high stakes. If you don't treat it, the patient could die. If you do treat it, the patient could die. So, what is there to love? But personally, I find diabetes a really interesting and actually rewarding condition to try and manage. For me, it's that sort of perfect mixture of the science and the art of veterinary medicine. Is the fact that a tiny drop of clear fluid can make such a big difference to a patient's physiology. And I really do think that we have a lot of leeway to make a massive difference to a patient's quality of life. So, although it says obviously setting you up for sweet success, I will be honest, this talk is not going to provide you with a simple recipe because that doesn't exist. What I'm going to aim to do is to give you a bit of a toolkit to try and maximize your success in managing these tricky patients. So, what are we going to be looking at? I'm afraid at the start we are going to be revisiting pathophysiology as much as, I don't know, it's no one's favourite, but hopefully just trying to show how the elements of this are actually really important for our understanding as to how we manage and monitor diabetes ongoing. We'll then look at risk factors. I know a lot of you are very well aware of these, but again, it's important for us to try and identify these patients that are going to be at risk potentially even before they develop diabetes, and know how we can intervene because, as ever, prevention is better than cure. Then I'm going to talk you through sort of as though we're going through 3 different consults. Consult 1, where you obviously diagnose the patient and have to get them started on treatment. Consult 2, within that first week where we're checking in, starting on monitoring. And then consult 3, at some point in the future, talking more about troubleshooting for those tricky patients. Now, this is a topic that we could devote entire sort of, theories of lectures to. So it is going to be really whistle stop. There are some things I won't be covering in huge depth, but do feel free just to ask us a question. We can come back to it at the end. So first off, where does it all go wrong? Starting off really nice and simply, we're going to look at the 3 big players we need to be aware of. Obviously, glucose, our most basic sugar molecule. And this is what we're mainly trying to regulate, obviously, when we're talking about diabetes. Then insulin. Very important. But the one thing I would say here is that we classically get into this mindset of thinking insulin is just about lowering blood glucose. But I think it's really important to think about insulin as this hormone of plenty because it does so much more than that. It is stimulated by hypoglycemia and with the aim of lowering glucose concentration, mainly by uptake into the skeletal muscle, get these translocation of GLUT4 channels into the skeletal muscle membranes. But beyond that, what insulin is aiming to do is to produce storage molecules. So it stimulates glycogenesis in the liver, increases lipogenesis, and also just uptake of amino acids into the cell. So all these building blocks. And really key, and we'll be coming back to this a few times, is that it prevents energy store breakdown. So it inhibits gluconeogenesis, production of more glucose, and breakdown of proteins and fats. So say that's really key. And then finally, and I think often does get overlooked a lot of the time, we have glucagon, which is probably our main catabolic hormone in the body. So whereas insulin builds things up, glucagon breaks them down. And the main kind of role of glucagon is to counteract insulin, aiming to increase blood glucose back to a normal set point, mainly by increasing hepatic glucose production. But if we're talking about hormones that do counteract insulin, we also just need to be aware of these ones in the middle, our stress hormones, so adrenaline, cortisol, and growth hormone. And all of these have negative impacts on the insulin signaling cascade, sometimes appropriately, sometimes not so appropriately. So very simple, but obviously we've got to be careful about how we define diabetes mellitus. So we're talking about hyperglycemia due to insufficient insulin activity, and that can also be absolute if we get insufficient production of insulin, or relative if we're just not getting a good enough insulin response. And obviously this is what we're mainly talking about when we're looking at our feline patients. So insulin resistance in people, we talk about type 2 or non-insulin dependent diabetes mellitus. And this has a prevalence in the kind of general cat population in the UK of about 1 in 200. So you're obviously going to be seeing them out there on a weekly basis. And what we're getting here is this lack of peripheral response to insulin. And this can be due to a number of things. And some of the key players, for example, are obesity, inflammation, and probably genes as well. So in terms of obesity, we know that if you're obese as a cat, you get an over 50% reduction in your insulin sensitivity. This is because the adipose tissue impairs insulin ability to promote glucose uptake, both in the fat and in the muscle, and it results in increased circulating glucose. Also, one point I just want to kind of bring your attention to here, if we look at this big diagram of adipocyte, is showing that adipose tissue is active. It's not just sitting there as these fat stores. They actually generate inflammatory cytokines, which can worsen your response to insulin. The added problem is, as you can see, obesity through increasing insulin resistance leads to hyperinsulinemia. The problem is, insulin, as we've discussed, is an anabolic hormone, so it does build you up. So actually, high levels of insulin, particularly before you reach the diabetic state, can promote obesity further. We'll come into these sort of vicious cycles in a moment. So initially, the potential changes in the pancreas, for example, causing beta cell exhaustion, can be reversible. But over time, they may become permanent. And this little image on the slide shows histopathology of the pancreas of two cats that had undergone infusions for 10 days, one just with saline and one with glucose, holding their blood glucose level at around 25 to 30 millimoles per litre. And you can just see the significant reduction in beta cells there. So glucotoxicity is a massive problem for our feline patients. And if this occurs over a long period of time, we end up with absolute insulin deficiency, so lack of insulin production, which in people is our type 1 or insulin-dependent diabetes. And essentially here, we've got reduced islets with reduced beta cells, much less ability to actually produce insulin. And the main cause, as we just said, is chronic hyperglycemia causing beta cell toxicity. But there are a few others as well here. So insulin is co-secreted with something called islet amyloid polypeptide, which is a protein that, as it's broken down, produces amyloid, this sort of slightly oddly shaped protein that can get deposited within the islets. And that's what this image is, this sort of streaky purple stuff is amyloid that's deposited in the pancreas. So there is a suspicion that in a patient trying to produce more insulin over time, when they're insulin resistant, they may get this increased amyloid deposition and eventually taking over from their beta cells. I say this theoretically because actually you don't see it that much in cat pancreases on histology, but something to be aware of. Obviously, chronic pancreatitis in these patients that have it over time, we get fibrous tissue builds up, scar tissue taking over from beta cells. This autoimmune beta cell destruction, to be honest, is really just in dogs, but probably are some cats where it's a problem. And very rare, but a pancreatectomy, if the patient has part of the pancreas removed for some reason, can obviously reduce your ability to produce insulin. So we're about to come on to a really unpleasant slide, just to show you what a hot mess all of this becomes. So essentially, in a patient with hypoglycemia, that's obviously going to trigger an increase in insulin production, which should lower your glucose. But in a state of insulin resistance, this obviously impairs glucose dispersal. So when we're talking about insulin resistance, we're mainly thinking of our issues being in terms of skeletal muscle not having these GLUT4 receptors translocated into it, the liver not responding to the inhibition of new glucose production, so still pumping out more glucose, and fat also breaking down into fatty acids, because insulin normally inhibits hormone-sensitive lipase, which should stop, so that should stop fat breakdown. So all of this results in us having increased glucose in circulation. We add into that excess calories, that's also going to be promoting hyperglycemia. Then, as we've said, we've got obesity. So excess calories are going to promote the increased fat deposition. Obesity can promote insulin resistance because it disrupts, as I say, this downstream signaling of insulin. Insulin, as we say, can cause further obesity. Inflammation can cause insulin resistance, so particularly cytokines like TNF-alpha and IL-6 have been shown to interrupt insulin signaling. Also, we know that in patients with insulin resistance, they actually get a kind of production of macrophage chemoattractant protein, so it causes inflammation itself. Obesity causes inflammation as well. If we've got this going on over time, eventually we're going to end up with our beta cell loss and reduction in insulin production. And add to that hypoglycemia reducing beta cells, inflammation reducing beta cells, and as I say, it's a hot mess. It's horrible. So we've got to try and interrupt this. And this is where I'm bringing in this circle to show where we need to try and intervene with these patients. Once we move through to the right side of the screen, we're obviously just managing the situation, but we can actually try and improve matters if we act early on. Where ideally we'd love to act is in this pre-diabetic state. So this is a state of impaired glucose tolerance. And a lot of these cats will have a sort of resting hyperglycemia. Obviously, I know it's very hard to differentiate in a lot of our patients in hospital. And often they're not glucosuric yet because your glucose needs to exceed the renal filtration threshold, about 15 millimoles per litre in cats before we see this. So again, we're probably not seeing them being PUPD at all yet. And the way to, in theory, define this is with an intravenous glucose tolerance test. So you give a cat 0.5 gram per kilo of glucose and check them their blood glucose before and 2 hours later. And we say that really when cats getting to about 10 millimoles per litre, that's probably a pre-diabetic state. They're not dispersing their glucose as they should. Key really is to say that this can happen before a cat transitions into being diabetic, or we end up getting them into remission. They're always going to be considered in a pre-diabetic state, so we know they don't have great glucose handling. So obviously, as I said, we need to try and intervene early on if we can to avoid moving into that full beta cell loss stage. So can we predict which patient's going to be more at risk? So these are probably some of our most common risk factors for developing diabetes, and we can run through perhaps why some of them are more or less important. So body condition, I'm sure a lot of you are seeing more and more of these, what I call square cats, the ones that just fill the box when they come in. There was a survey done about 12 years ago now, which showed that obesity in the UK feline population was about 11%. It's probably higher now. And we know that obese cats are 4 times as likely to develop diabetes as their lean counterparts. Weight obviously isn't such a good way of assessing things because a Maine Coon is not going to weigh the same as your average domestic shorthair, even if they're both lovely and lean. But studies have shown that cats in the 5 to 6 kilo bracket are going to be 5 times as likely to develop diabetes as those that are less than 3 kilos. So keeping a cat nice and slim is really key. Age, we've got this little crusty cat here, and it's no surprise to anyone that patients are more likely to become diabetic as they get older. They're going to probably have had more insults to the pancreas, more time to develop any of these other risk factors. So, for example, if we look at a cat that's 3 to 6 years old, a cat that's in that 9 to 11-year-old age bracket is 17 times as likely to develop diabetes. So another thing it means is that if you're finding hyperglycemia in these young adult cats, we need to think about whether there's another cause. Then one interesting one is sex, gender, and how that is impacted. So male cats have an odds ratio of 1.6 times of developing diabetes. And we do know that males are more prone to insulin resistance. Males are also more prone to being obese. That's because they tend to be more lazy, tend to be more greedy. And it's key to know that correlation is not always causation. So is it just that male cats are separately prone to obesity and insulin resistance? But either way, not something we can do very much about, but something to be aware of. Breed. Now, I know this has been publicised quite a lot. Everyone knows about Burmese cats in particular, that are 4 times as likely as your average moggy to develop diabetes. I guess an interesting point is that that study was done in Commonwealth countries, and we do find very much breed-related differences in different countries. So different areas of the world may see a different predisposition. We've also got on there the Tonkinese, similar, about 4 times as likely as domestic shorthair cat, and Norwegian forest cats, about 3.5 times as likely to develop that. Moving on from there, diet, a very, very key one here. So the main risk factors we obviously have here, we've identified that dry food can be have a big impact. Again, odds ratio of almost 4 there. We can come on to why that is a bit later on. High carbohydrate food is a big problem because cats in the wild would eat almost entirely a protein-based diet. So they have evolved for their gluconeogenic kind of processes to be constitutively on. They're always in a state of trying to produce more glucose. They're not used to actually handling it in their diet. And so that we know cats that have sort of metabolizable energy levels of carbohydrates close to 50% in their food, which sadly some commercial diets are, show a much greater increase in their postprandial glucose levels compared to cats fed a more moderate diet. It can be up to sort of 10 millimoles per litre, even in a totally healthy cat. And then obviously cats that are fed ad lib, and particularly indoor cats fed ad lib, access all time, are much more likely to develop diabetes. Then we've got steroids. Now, this picture is quite a classic picture of a cat with hyperadrenocorticism. Now, this is really rare. I've not personally ever seen a case, and I'm quite glad because they develop this horrible skin fragility. Literally, you pick up their skin to give a subcutaneous injection and it just tears apart. And up to 90% of cats with hyperadrenocorticism are diabetic. Obviously, what we're going to see a lot more are cats that we put on steroids, so iatrogenic issues there. And this is because steroids, again, unlike insulin, are catabolic hormones. They're encouraging the production of glucose and fats, and they also interfere with the skeletal muscle uptake of glucose and encourage more fatty acids to be released into the bloodstream, which the beta cells hate. And a study done in JVIM, I think sort of 3 or 4 years ago, showed that almost 10% of cats on immunosuppressive doses of steroids ended up developing diabetes. Now, obviously, that's going to vary based on some of these other risk factors. So an older, fatter male cat put on steroids is going to be much more at risk than a young, skinny cat that doesn't have any other risk factors, but definitely something for us to be aware of. Now, pancreatitis is a bit of an interesting one. It's a bit of a sort of chicken and egg scenario because it's been documented that diabetic cats have an increased FPL on measurement. But it's also been shown that hyperglycemia encourages neutrophils into the pancreas. So whether it's the high glucose causing the inflammation or vice versa is a bit uncertain. And when they've done studies in cats that sadly deceased with or without diabetes, there's not been an obvious difference in the numbers of cats with pancreatitis on histology or not. So jury's still out of it. But one thing I think that we can all assume would logically occur is that in a cat with recurrent bouts of pancreatitis, so say maybe ending up with these pancreatic nodules, fibrous changes, that they probably do have a reduction in functional exocrine pancreatic tissue. So, something certainly for us to be aware of. And then finally, hypersomatotropism. So excess production of growth hormone, normally from a benign mass in the pituitary gland. And hypersomatotropism, I guess, is the sort of pedantic term for it. It's what's actually happening in the pituitary. Obviously, a lot of us know it as acromegaly, which is this phenotype, the really broad faces that we get in these cats. Now, with this disease, let's say we get increased growth hormone, which increases the production of something called IGF-1. Now, this acts in the liver to uncouple basically the insulin pathway, meaning that, again, we stop inhibiting glucose production in the liver, much more likely to get hyperglycemia. And a study done, again, probably best part of a decade ago now, suggested that about a quarter of diabetic UK cats had hypersomatotropism. So definitely something to look out for. I'll be honest, maybe in my experience, I test a lot for it, don't find that many that have it, but we'll talk about which cats are particularly key to look for it in. And I just really love this photo because I just like the idea of this little cat in the kennel, just being totally amazed at his huge giant neighbour. So, as I say, we've got all of these risk factors here, but it's only any use knowing about these if we actually do something about it. So some of them, we can't do anything about the age or sex or breed of our patient. But I've highlighted the ones I think we do have some leeway over. With pancreatitis being kind of in the middle, we can obviously try and reduce the risk of pancreatitis, but can't completely get rid of it. So, okay, we know why it's occurring, we know which patients it's most likely to occur in, but what happens when we're actually confronted with a diabetic? So this is our consult one. So the first day when they're walking in through the door, and we're going to sort of think about the 3 different elements we need: the diagnosis, discussion, and then also treatment and initiating treatment with these patients. Now, again, I know this is probably a bit pernickety, but it's always good to really clarify what we're talking about when we're saying the diagnosis of diabetes. So this criteria, the ALIVE criteria, is something set up by the European Society of Veterinary Endocrinology. It's called Agreed Language in Veterinary Endocrinology, just so we're essentially all singing from the same hymn sheet. So to be diagnosed, you need to have a blood glucose of greater than or equal to 15 millimoles per litre, again above our renal threshold. compatible clinical signs, as we'll come on to. And then they, at the moment, classify it as either documenting increased fructosamine concentration or finding glucosuria on at least one occasion. Because there can be some variations in fructosamine measurements. So when we're talking about diabetic diagnosis, this is what we mean. So I probably don't need to talk to you that much about the clinical signs or initial diagnostic tests. We'll just quickly run through them. So obviously we've got our polyuria and polydipsia due to the osmotic diuresis, this glucose being in the urine, drawing extra water in. It's got polyphagia because, although we've got a lot of glucose in circulation, the lack of response to insulin means that the body isn't able to take it up. So I always think of diabetes as being sort of a disease of starvation. The body feels as though it's in this fasting state all the time. This is also why we then end up with weight loss. And this picture here at the bottom is as close as I can come to a clip-art picture of a cat with a neuropathy. They're sitting down, let's just say. Their back legs aren't working so well. And so neuropathy occurs in cats due to prolonged glucose toxicity. Occurs in about 10% of diabetic patients and tends to be a marker of chronicity because it's the ongoing impact of glucose on neuronal transmission. The reason it tends to manifest in the pelvic limbs is because it's more likely to affect longer nerves, like femoral nerves. And it's something I've always found quite disappointing when you find, because I've always felt there's not much you can do about it, but we'll come back to it, which is exciting. And then our basic diagnostic tests. Again, I'm not going to run through this in huge detail. I know most of you are all well versed in this. We've obviously got blood glucose measurement. Now, interestingly, normal blood glucose is not terribly well defined in cats, but a lot of studies use sort of 3.3 to 6.2 millimoles per litre as normal. And then obviously with diabetic, especially we need them to be above 15. We've got urine dipsticks. Again, this is looking for glucose concentration in the blood exceeding renal threshold, and then fructosamine measurements. So fructosamine is glycated albumin, glucose sort of stuck onto albumin's protein in the blood, and it's a rough indicator of glucose over the past, say, 2 weeks. Now, key things to remember are that the reference intervals are very specific to the test. So if you measure with IDEX, use their reference range. If you measure with Axiom, use theirs. They're not interchangeable. And also the one thing in particular that can really make it difficult to interpret fructosamine is hypothyroidism. In a cat that's untreated, that increases your protein turnover. So you could end up with an artificially low fructosamine. So just something to bear in mind. But as we all know, hyperglycemia is not always diabetes. So stress hypoglycemia is obviously a big problem in our feline patients and occurs in, I would say personally, at least a third of hospitalized cats, if not more. The same study said that it could be as high as 33 millimoles per litre. I'll be honest, I think I've seen probably highest of around 20. They are often in the teens. So it is hard to say that one specific cutoff is or isn't a stress response. And it lasts for essentially as long as the stress does. So obviously, if you've got a patient in hospital for a long time, you would hope it would damp down. And also, when is glucosuria not diabetes? So as we say, the main one is stress hypoglycemia. But we can also see it in other situations. So tubular injury, for example, and about 30% of cats with an acute kidney injury will end up with glucosuria just because the tubules are so damaged they can't reabsorb glucose. But hopefully you'll already be well aware that that cat is suffering from a severe kidney injury. Quite an interesting one is chlorambucil. No one's quite sure how this happens, but it is very common for cats that are receiving chlorambucil ongoing, so particularly our cats with, say, small cell GI lymphoma or a chronic enteropathy, to have a low level of glucosuria. So still obviously check their blood glucose, but it's definitely an issue to be aware of. And then finally, containers. I remember having a client bring in a urine sample that I think I was just checking for USG or proteinuria and being shocked at there being 4+ glucose, but they just decided to put it in an unclean jam jar. So it's a niche one, but something to be aware of. So that's obviously those are our diagnostic tests, our keys to saying this patient has diabetes. But I think it's important to talk about ancillary testing, what we'd consider a minimum database and really should be done in every patient, and then what I would consider are extra or bonus investigations. Because yes, to be honest, your patient comes to the RAF, they'll probably have all these investigations, but it's not going to be right for every patient. We don't want to be putting clients off treating their pets because they've got to do every test under the sun, either financially or because they don't want to put their pet through it. So how we choose which pets we test for what. So I would consider a minimum database for us to be, serum biochemistry, CBC, and a urinalysis. And these are some of the common findings we can see. As we say, the liver is under extreme stress in diabetes. It's constantly trying to churn out glucose despite there being so much in the bloodstream. And we get hyperlipemia as well, because we're not inhibiting breakdown from adipose tissue. In terms of hematology, again, quite non-specific, probably a mild non-regenerative anemia. And then with the urinalysis, one key thing is to note that glucose can impact on your measurement of USG via refractometer. Some papers say it's not a huge amount, but I have definitely seen patients that I know exceedingly, have significant kidney injury that seem to have good urine concentrating capacity because they've still got high glucose levels. And obviously, are very key for later on, checking for ketones as well. But then there are definitely some extra investigations to consider. So thyroid measurement, obviously these cats are often quite obvious, but they'll already be having weight loss and an increased appetite. But if they're significantly older, have cardiac changes, or you can palpate a goiter. Urine culture, I guess, is a little bit controversial. Classically, we'd say in any diabetic patient to check it, but I guess we're becoming more and more aware that we don't treat bacteria in the urine without clinical signs. But certainly if they've got obvious signs either of lower urinary tract disease or they're azootemic, I'd consider treating them. If they've got renal pain or potentially if they're unwell, it might be worth just checking your urine culture. With pancreatic testing, I'd consider assessing for pancreatitis if not eating, vomiting. I put discomfort in brackets because cats are such a nightmare. They don't always show obvious abdominal pain, even with really severe pancreatitis. And then with the opposite, measuring TLI, so to look at our exocrine pancreatic function. Cats with chronic weight loss, difficult to tell when they've got diabetes, or chronic diarrhea. And honestly, weight loss is actually seen more in cats with EPI than diarrhea, so something to have on your radar. I would definitely recommend imaging for cats that are generally unwell. Either they are truly in DKA or you just can't quite pin down why they're seeming so poorly with diabetes alone. And then IGF-1, coming back to this, looking for hypersomatotropism. So the key one here for me is a diabetic cat that's poorly controlled but is gaining weight, because that just shouldn't happen. And that's because, again, growth hormone is a very anabolic hormone. They get these classic facial changes, and stride or snoring is reported in probably about 50% or so of patients. One thing just to mention is that IGF-1 measurements increase when a patient is given insulin. So whilst most patients you can probably diagnose with the first blood test when you first meet them, in ones that are a bit borderline, it could be worth checking them if you are treating with insulin, sort of a month or two later on. And this is a patient I had a number of years ago, Mr. Mungus, who's this lovely Maine Coon, obviously very big to begin with. But there were some great photos that his carer had from the previous year and then when I met him. And you can see this sort of really enlarged brow, the sort of changes in his facial shape, really broad muzzle and these huge paws. So some of them are quite easy to spot, some of them can be a bit more challenging. So we've diagnosed them. Now we've got to go about starting treatment. And this is why I get really excited, because obviously we're going to be talking a lot about the latest development in diabetes. We'll be briefly touching on insulin because it's now a bit old hat, but just talking about a few things to know. Diet and weight loss, as we've already said, are key. And then finally, just talking about when diabetes is actually a surgical disease. So I was looking back at some slides from a talk I did about 4 years ago, and clearly I was manifesting something. So I said, watch this space. And I'm very pleased to say that we are really lucky to be around at a time where we've got a real revolution in the treatment of diabetes. And I'm sure probably quite a lot of you have been bored to death with this already by various reps or talks at London Vet Show, but just to run through this with you. This big change is a drug called velagliflozin. So this is a sodium glucose co-transporter 2 inhibitor. So sodium glucose co-transporters use the electrochemical gradient generated by sodium potassium ATPases. So here is our luminal membrane with the SGLT1 or 2 transporter, and then we've got our sodium potassium ATPases on the basolateral membrane driving that gradient. And so the idea is that these transporters uptake sodium and glucose together. SGLT2 is the one we're most interested in, and this is a low affinity but really high capacity channel. And it's responsible for about 90% of glucose reabsorption. And we're talking particularly in the proximal convoluted tubule of the kidney. So it's responsible for, let's say, the vast majority of glucose reabsorption. We do have another channel, SGLT1, that's present mainly lower down the renal tubule and in much higher levels in the gut, which is something important to remember later on. And that has a much lower capacity. It's only responsible for about 10% of glucose reabsorption. And by inhibiting these transporters, particularly SGLT2, we stop this reabsorption of glucose that's quite normal in the tubules. So classically, glucose is filtered out through our glomeruli into the ultrafiltrate and then reabsorbed into the tubules. Obviously, if we have a blood glucose concentration of greater than 15, we're going to get some loss in the urine anyway. Otherwise, most glucose is reabsorbed. If we block this by inhibiting this co-transporter, glucose just carries on through and is lost in the urine. And this family of drugs has been used for quite a long time in people, and it's well documented that SGLT2 inhibition reduces blood glucose, it reduces insulin resistance, and it even reduces blood pressure. And actually, they seem to be using this family of drugs for so many different things in people now for certain heart diseases. I've even heard a rumor it's being used for certain forms of alcohol addiction. I have no idea how that works, but apparently they're fantastic. So there may be more to come on to. And going back to this nasty diagram, what we're really trying to do is kind of intervene with these patients right at the start by reducing this hyperglycemia that kicks off all the cycles. And the reason why I think this is particularly important, and some of you may have heard this statistic already, is that studies have shown that up to 30% of diabetic cats are euthanized within a year of diagnosis. So about 10% of cats diagnosed with diabetes are euthanized pretty much at that first consult. And at least another 10% within that first year. And, it is a lot for people to be taking on. They may have concerns about their lifestyle. Giving insulin injections twice a day is very restrictive. I love diabetes, and I don't think I could necessarily sign up to that. And we know people feel it restricts their social life, their ability to travel. There's going to be the fear. A lot of people aren't used to handling needles, having to give injections, especially with such a kind of potent drug, can be really terrifying. And then there's also the ongoing cost of the insulin, the needles, the disposal, the monitoring. So whilst it's been the only thing we really had for a long time, we knew there had to be a better way. And so this is where vilaglyphosine comes in. And this is just a little bit of a comparator for you between insulin and vilaglyphosine. So it's an oral drug already, much more palatable for carers as well as their cats. Once daily dosing, easier. It's also a consistent doser rather than with insulin where we're varying up and down. It's a very specific dose per weight. We'll come on to this in a bit, but there is minimal risk of hypoglycemia. And we know that generates a lot of kind of worry for clients otherwise. So to get rid of that is really nice. And there are no storage conditions. So rather than having to put the insulin in the cold pack if you're traveling somewhere, obviously we don't want to have it on the Arga, but other than that, it can be used, stored anywhere. And for those of us more interested in sustainability, most bottles last for, say, an average for about 3 months. So you use one syringe per 3 months compared to, say, up to 180 in a cat receiving insulin injections, which is something to be aware of. So this diagram, which is where it all starts to get quite exciting, derived from a study done in Europe comparing 61 cats receiving vilaglyphosine with about 60 cats receiving insulin. They included both newly diagnosed and insulin pre-treated cats, and they randomized them as to which treatment arm they were in. And what you can see here is the average blood glucose when they had blood glucose curves done at 1 week, 2 weeks, 4 weeks, and then at 2 months. And I think it's quite startling to see that very rapidly vilaglyphosine lowers the glucose concentration below this kind of renal filtration, renal reabsorption capacity, much in advance of insulin achieving that. And it stays that way for those 2 months. So, definitely something that as soon as people were seeing this data, we're quite excited to try and explore further. This is something I know I mentioned it just now, but looking at diabetic neuropathy, um, where this was actually from an American study with about 250 cats just treated with belogliflozin. There were 26 cats in there with the diabetic neuropathy. And amazingly, over the 6-month period that they were assessed for, 77% of them improved in terms of their nerve function. We think this is because the key to resolving a neuropathy is to stop the glucose toxicity. And whereas with insulin treatment, we're still probably going to have periods of hypoglycemia, with belogliflozin, we get this flat line normoglycemia, so giving the nerves much better ability to resolve. I guess one thing when I first heard about this drug was wondering, well, okay, if we're worsening glucosuria, are we going to get a massive increase in polydipsia? Interestingly, that doesn't seem to be the case. So this is probably because the initial increase in glucosuria is quickly negated by the fact that through feedback loops, we're reducing the blood glucose. So there's going to be less glucose filtering out into the urine. And also because the kidney can adapt by inserting extra channels in to absorb water, so aquaporins and sodium potassium chloride transporters. So as you can see, even within the first week, more than 50% of patients had a reduction as perceived by the carer in their polydipsia. And that had increased to, so 88% over the 3 months. So really interesting that despite its mechanism of action, it makes a big difference to clinical signs. But hopefully you're now sold. You definitely want to give it a go. But we obviously need to talk about potential adverse events with this. So diarrhea is probably the most common. It happens in about half of cats treated with belogliflozin, normally within the first week or so. And this is because it has some level of inhibition of SGLT1 transporters, which are in the small intestine. So you get then a bit of loss of glucose and therefore water in the guts. But this is very mild, normally self-limiting. And apparently, a lot of the people that took part in the study said that actually, if they weren't having to fill out a questionnaire, they wouldn't have even said their cat had diarrhea. So technically they did, but they didn't find it an issue. And less than 2% of cats had diarrhea severe enough that they needed to stop treatment. So if a cat does have slightly loose stools, see if you can get them to push on for a couple of weeks and see how you get on. Vomiting, and again, but in about a third of patients, fairly sporadic, normally self-limiting. I would say the cats that I'm aware of that have had vomiting with belogliflozin are ones where perhaps it's been given directly by mouth or not with food. It's specifically designed that it can go with food. So I think that would be the first thing I'd troubleshoot there. UTI, this is an interesting one in that the European study did show perhaps slightly more positive urine cultures after receiving belogliflozin versus beforehand. So 19 cats versus 25 cats afterwards. But these were just urine cultures. They did not look at clinical signs. So again, we don't know if it was true UTI or just bacteriuria. Hypoglycemia, as we said, this can be a real concern for carers when they're treating their cats with insulin. And between the two studies, the level of instance of hypoglycemia measured numerically on an alpha track was between 5 and 13%. But none of the cats had clinical signs. Now, if we compare this to the European study where there were insulin-treated cats as well, 45% of those cats had numerical hypoglycemia and about 8% of cats were clinical. So quite a big difference there. And then finally, the one you might not have heard of, and which is kind of new to most of our lexicons when thinking about diabetes, is euglycemic diabetic ketoacidosis. So obviously we know that a patient with DKA is ketotic and acidotic, but now we've realized in patients being treated with SGLT2 inhibitors, they may or may not have hyperglycemia. And in fact, 75% of cats developing DKA receiving belogliflozin had normoglycemia. So something we have to really be aware of. And the reason that this tends to happen is if we go back to insulin both lowers blood glucose, but is also inhibiting ketogenesis. Belogliflozin is lowering blood glucose, but does nothing to inhibit ketogenesis. So we are more likely in cats that don't have a degree of underlying insulin production to enter a ketotic state. Also, we in humans, they're aware that SGLT2 inhibitors can actually activate glucagon release. So that kind of further puts us in this kind of catabolic state for potentially precipitating DKA. So this was, or DKA as a whole, was seen in about sort of 1 in 15 cats, about 75% of those, as we say, having euglycemic DKA. And the vast majority of them were in the first 14 days of starting treatment. So that's the real time to be concerned about them. And there was a much greater likelihood if the cats had already received insulin. They're about nearly 3 times as likely to develop euglycemic DKA as a cat that hadn't received it. And this probably just reflects that they've had the disease for longer, and that they probably have less endogenous ability to produce insulin. So, key thing to remember, if you've got a cat receiving a SGLT2 inhibitor and they look at you even slightly askance, check their ketones, even if they're normoglycemic. So unless you've been living under a rock that somehow Boehringer have not managed to infiltrate with a lunch and learn, you will have heard about Zenvelgo, which is the marketable version now of felagliclose. And so the dose for this is 1 mg/kg once a day. Can be plus or minus food. So easier, why not just give it on food? May reduce the incidence of vomiting. It is very palatable. Apparently it's the same flavouring as Metacam. And so apparently they have a 98.2% success rate in terms of medicating cats. And if you kind of calculate it out, a 30 ml bottle lasts for about 3 months in a 5 kilo cat. So at the moment, depending on markups and such, that works out around £100 a month, and probably will become cheaper if you have a prescription to buy it online or just over time. And Boehringer, I'm sure you've seen, have produced this really nice flow chart for which cats to put on Zenvelgo or not, and how to monitor them. And just the 2 key things to highlight from here, which I'm sure a lot of people are already aware of, is that Zenvelgo is only for patients without significant comorbidities, because we do have this impact on their metabolic state. So they have to be these happy diabetics. Diabetes seems to be their only issue. And that ketone measurement is really key, initially every 1 to 3 days when they're at home. So just to give you a little bit of a brain break, just wanted to have a chat about some other oral anti-hypoglycemics. And this is something that blows my mind about how scientific progress can work. So this is a Gila monster. And someone realized if you get bitten by a Gila monster, you collapse in a hypoglycemic coma. And so it turns out that Gila monster produces something in their saliva that is an analog of what's called glucagon-like peptide 1. So this is an incretin, something that it potentiates insulin release. So you get this massive insulin release. And someone thought, well, let's market that. So there's a drug called exenatide, which is a synthetic version of Gila monster saliva. It's been used in cats, sadly with fairly modest success. I just think it's amazing that we can look at a lizard and decide to make a drug for it. It's brilliant. So moving on now from all the new exciting stuff to our old friends insulin, we'll just go through this very quickly. So what we're talking about on this page is lente insulin, so our sort of relatively slow acting insulins. We've got pan-insulin, which is a porcine-derived insulin, and then Prozase. This is protamine zinc insulin, as the name says, and it's a recombinant human insulin. And overall, we tend to see slightly longer duration of action with Prozase, which is the reason why I tend to prioritize it for cats. This would be my go-to insulin for use in feline patients. And this is because the size of the zinc that's attached to the insulin crystals slows down absorption. So you get this longer duration. You can also, and some of you may have seen this in your glucose curves, get a bit of a biphasic peak when the smaller crystals and then the larger ones get absorbed. Whilst in dogs it's marketed as once-day dosing, I would definitely say twice daily in cats because they have a shorter duration of action. This is our sort of rough guide to dosing. I'm just going to very briefly mention that it is off license. Have to let you know that. So this is insulin glargine or Lantus, which is an insulin mainly used in people. It's a synthetic analog of human insulin. And the amino acid changes to the insulin means it's absorbed very slowly because it's much less absorbable in the neutral pH of the subcutaneous space. So in theory, it's peakless, just has a nice basal level of insulin. And the reason I mention this is because if you read papers on diabetes, particularly ones that come out of Australia or America, they go straight to using this. They don't have the cascade like we do. If you are ever at a point of using this, and when I've exhausted the licensed options, I do sometimes end up with this. The Junior Star pen I've got a picture of here is very much what I would recommend for dosing. It's been proven to be much more accurate even than veterinary professionals drawing up insulin syringes, and it can go up in half units. Because really key to note is that insulin glargine is much more concentrated. All human insulins tend to be at least 100 units per mil, so we can't use our standard syringes anyway. So this slide, I'm just going to leave up for a moment. It's got a few links here for you because, as I mentioned, you're going to need to have all of this discussion with the carers about the diagnosis, what it means, how you're going to treat, how you're going to give the drugs. And you don't have time for that in a 15-minute consult. So ProZinc website actually does have some useful carer handouts as well. YouTube can tell you how to do anything, so I often direct clients towards that as well. Even if you've shown them how to inject, there's only so much they can take in one go. And this QR code at the bottom is just for you to be able to access the handout that we give to people when we diagnose their cats with diabetes. So you may well have your own handouts already, but just gives you something to use if you're a bit short on time. As I said, diet is going to be really key. And this is because cats just weren't designed to eat carbohydrates, essentially. So they tend to eat sort of less than 2% of their metabolizable energy as carbohydrates in the wild. And so they are prone to prolonged postprandial hypoglycemia after eating carbohydrates. They can have hypoglycemia for 8 to 15 hours compared to, say, 3 hours in the dog. So what we're aiming to do with our diabetic diets is to give them high levels of protein. So, the vast majority of their energy is protein, much less as carbohydrates. And we've proven that cats on low carbohydrate diets are far more likely to enter remission. So about 68% of cats on a low carb diet will enter remission compared to, say, 40% of cats fed a more standard diet. Other key changes in diabetic foods are having high fiber. This slows glucose absorption, also promotes satiety, which is great in cats you're trying to promote weight loss for. And wet food is also really useful from this perspective. This is because not only does dry food have added carbohydrates in the processing of it, that sort of extrusion process, but it's got a much higher energy density. So cats feel they've eaten much less to get their sort of standard calorie intake. And we end up finding they feel much less full. So that tends to be, these are the ones I would tend to go for. And just here again, here's a comparison showing what our ideal diabetic diets would look like compared to, I swear, pretty much all of my diabetic patients only want to eat Felix. And this is why it's so much worse than we've got more than 5 times the level of carbohydrate in Felix, sadly. Weight loss. I appreciate it's much easier said than done, but it's super important. They've shown that for every 1 kilo in weight increase that a cat has, they get a 30% reduction in their insulin sensitivity. So if we can shed some of those pounds, we can really improve their ability to respond to insulin, both administered and endogenous. And again, we recommend feeding wet food to help these cats to eat less because it's got less energy density, they're going to feed fuller. But we are aiming very much for kind of sustained gradual weight loss. I know this can be difficult when we're managing a diabetic cat. Are they losing weight because they're not well controlled, or are they losing weight because we want them to? So generally looking at their other clinical signs is going to be important as well. And I put increased exercise here because whilst that's nice and easy in a dog, it is much more difficult in a cat. A couple of options. On the right here, we've got those mats with the sort of fake mouse tail. We use them quite a bit in the hospital. Cats seem to love them. More recently, I've been hearing of cats having cat wheels. They seem to be this big hamster wheel type contraction. Some cats might enjoy them. I would say I had one cat referred recently for compulsive running and screaming on their wheel, which I don't think was a medical issue, but something to be aware of. And finally, I found this, a light up scratching post. I don't have a cat at the moment, but I consider getting one of these. So there are definitely creative ways of trying to get your cats to move more. And then finally, when is diabetes not just a medical issue? When is it surgical? So we've already talked about hypersomatotropism. and the fact that these cats have a pituitary mass, which we can see nicely highlighted on CT here. And actually, it's probably the one time that we prefer a CT for looking at an intracranial mass rather than an MRI, because it shows up really nicely with contrast. And so our recommended treatment is removal of the mass. They're generally, fortunately, benign. And this occurs via an incision in the palate. It's amazing. They then drill up and scoop out the pituitary gland, which is definitely beyond my scope, but very impressive. The one thing that we definitely have to make carers aware of is we're not then going to be able to stop giving cat medication. We solve one problem, we're not going to hopefully be having to deal with the diabetes, but they do need lifelong hormonal supplementation. Essentially, they need cortisol replacement and thyroid hormone replacement. And for a variable amount of time, they'll need antidiuretic hormone as well. But because that's actually produced in the hypothalamus, so above the pituitary, they can over time redevelop the ability to produce them. And this can resolve diabetes in at least 70% of cats with hypersomatotropism. It occurs normally within the first 2 months. I'd say in my experience, it's often you can see signs of that within the first week of them going into remission. And even if they don't enter remission, they're generally much more, have significant improvement in their diabetic control. So consult one done. Moving on now for when this patient comes back, how are we going to monitor them? How are we going to consider adjusting our doses? So in terms of monitoring, again, I'm not really going to talk that much about the top three because I know you all know how to do those, but just to point out that whereas before, as a medic, someone saying they were monitoring a diabetic with a spot blood glucose, perish the thought. Actually, potentially there is some utility now with gliflozin because they do end up with this flat line glucose level. And so fructosin might also be more useful as well. And urine monitoring is really key, obviously, when we've got a cat on Sembelvo, because we need to be checking for ketones. Otherwise, I'm just going to have a bit of a chat with you about continuous interstitial glucose monitoring, and then, silly as it may sound, monitoring clinical signs. So I know that a lot of you are already using these in practice, but continuous interstitial glucose monitoring, we tend to use a sensor called the Freestyle Libre 2, which you can see attached to this cat here. This acts by something called wireless enzyme technology. So essentially, there's a little needle that's inserted into the subcutaneous tissue, and that has an enzyme attached that reacts with glucose to release electrons that then send a tiny little electrical impulse up to the sensor in that white disc. And it generates information every minute about the interstitial glucose, which is key, not the blood glucose, because whilst blood and the interstitium do equilibrate, there is a lag time of between sort of 5 and 12 minutes in doing so. So it's still very good in our sort of long-term diabetic patients, but in a patient having big swings, say in hospital, we might need to have more real-time monitoring. And one thing I would just say, even for those of you already using the Freestyle Libre, is to definitely look at signing up to this LibreView cloud system, because I find a lot of vets have screenshots sent through from carers on their phones, which can be actually quite hard to interpret and track. But if you set up this cloud system and assign your practice as a healthcare professional, you can then invite carers to share their data and it comes up automatically on your laptop. So much, much easier to monitor and to assess. So that would be my top tip there. And this isn't just us going off piste, it has been validated for use in cats. So there was a study, I think last year or the year before, and they took 8 cats and 3 times over sort of a few weeks, they did paired blood glucose curves with having a freestyle on. And as you can see, there really generally was pretty good agreement there. It's not perfect, but in dogs, they've looked at what degree of readings from blood versus interstitium would give you the same clinical decision making, and it's really excellent. So still a very useful thing to measure. So the benefits, as I say, continuous data. So we know from studying blood glucose curves that you can miss the nadir in almost 60% of cases. So if we're just plotting points every 2 hours, we're assuming that the line we draw between them is accurate. When you do use continuous interstitial glucose monitoring, you can see that it can go all over the place. So we can be missing these. And that's going to be interesting for us in terms of determining if we adjust our insulin doses. Also, as much as we might think we've got a routine, we're feeding the cat the same every day, we're giving the same insulin every day, insulin recommendations can vary in up to 64% of patients on a day-to-day level. And this is because we're dealing with a really complex biological system. It's not a car or some sort of machine. So if you just do a blood glucose curve on one day, you may think a patient is beautifully controlled, and then do one the next day and it looks awful. So having this sort of run through of multiple days in one go can actually be really insightful. One thing that I found really useful, and at first thought it was just me, but it has been documenting quite a few of the studies now using interstitial glucose monitoring, is a lot of patients are hypoglycemic overnight. I think traditionally we've often worried that, because they're not eating overnight compared to during the day, that they're more likely to go hypoglycemic. But particularly between the hours of 1 and 6, we found patients quite likely to have more hyperglycemic events than during the day. Well, quite possibly this is because patients are moving around less overnight, maybe not cats, but their movement and that exercise actually generates GLUT4 transporters being uptaken into the skeletal muscle membrane, so encourages uptake of glucose. So I've got quite a lot of patients now where I give them less glucose, different amounts of glucose in the morning and in the evening, and quite often it's higher at night. So it's an interesting point. It reduces patient stress. So we know, obviously, cats, particularly with their stress hyperglycemia, are going to perhaps have higher glucose readings than we'd expect. They're also not going about their normal day-to-day activities. They may not eat the same amounts, and so we're not going to get an accurate representation from a hospitalized blood glucose curve. And reduces client stress. Apparently 80% of clients find it less stressful than blood glucose curves, particularly ones they do at home, which I'd say overall is understandable, but I will come back to those 20% of clients where a little bit of information is a lot for them to take on. And for those of you that aren't so well versed, just wanted to show you some curves here. Now, full disclosure, this is a dog. I don't currently have a cat I'm giving 12 units of insulin to, but just to show you how we get this sort of continuous line that isn't just perfectly up and down. And so we can see where we're giving our insulin at the times when we're hypoglycemic. This is an example, as I said, of nocturnal hyperglycemia. So lovely curve during the day. If we did a blood glucose curve then, we'd think they were brilliantly controlled, but then wonder why are they PUPD overnight. So that's, again, one of the benefits of this type of monitoring. This is an example of a patient with an overswing. So we've got low glucose now, and then higher glucose later on. And then finally, this is one I really like, which is a patient appearing to go into diabetic remission. But a bit of a note of caution. There is a discrepancy between blood glucose and interstitial glucose. Let's say most patients, you'll still go through the same actions. The sensors don't always last that long, particularly in cats that scratch them off, because only about 40% of cats tolerate them well. And it is a reasonable cost if they're not going to be lasting that long. As I say, we do then have these carers that get a little bit obsessed. And so what I would say to wrap up that bit is that glucose monitoring is for trends. It's not for perfection. We're not looking at individual numbers. We're looking at how things vary day to day and say during the day or overnight. So whilst they're not ideal, I think they give us a lot of information, and I will put them on anything that moves. So this is a little alpaca cria I've treated with that.
Okay, so we did receive some questions before the webinar. The first one is, given that Semvalgo works on the kidneys, is it possible to use it in cats with CKD?
As I say, I just brought up that screen there showing that you, whilst Boehringer at the moment have to say you can't use it in cats unless they're perfectly healthy. Actually, if you do monitor cats with IO stage 1 or 2 CKD, well, you should be fine to use it.
Right, we do have another question. Are there any foods you recommend for cats if they really don't like the diabetic foods?
Yeah, so this is a really good point because some of them just refuse to eat it. Otherwise, I try to ideally go for things like the weight loss diets, anything that's got added fiber to it. If they still won't have that, then at least going for a wet food. You can there's a really great website called Balance It, and they've got this thing called a guaranteed analysis converter that lets you work out how much protein and carbohydrate there is in a diet. So you can at least look at that, maybe even add in extra fiber through things like ProFiber or Fibor just to try and supplement that.
Sorry, got to unmute. The joys of live IT issues. What would be the best test for long-term monitoring for cats and Semvalgo? For example, every 3mc fructosamine or blood glucose curve or blood glucose spot?
So at the moment, they're sort of trying to figure that out because they've only looked at cats over about a 6-month period. It does look as though in the cats that respond well to it, they're the ones you're going to know because they have kind of normalization of their clinical signs, that whilst it would be good to get a blood glucose curve every so often just to show it is a flat line, most of the time it is. So particularly if you've got a non-stressed cat, you can get blood glucose from in the clinic, or where they can take a blood glucose at home, a spot check, that should be fine. Obviously, we can't use glucosurea because that's going to be present. So fructosamine, as long as you've got a baseline to work through, would also be good. But yeah, I would say with a lot of these patients, I would go based more on clinical signs. And that was actually one of the slides I didn't quite get time to come to, because to be honest, clinical signs is really underutilized in diabetic monitoring overall. Our main aim is just to improve a patient's quality of life and reduce their clinical signs. So as long as a cat is maintaining weight, not PPD, eating well, then you maybe can get away with kind of more hands-off monitoring.
Okay, so another question. What is the best way to measure ketones in cats that have been started on Selvalgo? Do normal urine dipsticks measure this sufficiently?
So fabulous question. I am just going to share my screen again, if that's okay. Just because I do have a little slide on this just to run through with you, because this is something they really thought about when designing the protocols. Because yes, urine dipsticks measure a different kind of ketone body to blood. So measure acetoacetate rather than beta-hydroxybutyrate. And actually, particularly in diabetic ketoacidotic states, you produce much more BHB than acetoacetate. But we appreciate that not everyone has access to ketometers. So that's why they've designed this with ketonuria in mind. So it's going to be good enough to assess for ketones initially. If you do have the ability to measure blood ketones, that is great. But what I would say is that the jury's still out a bit on exactly what's normal. So I think we can say that anything less than 0.9 to 1 is normal. Whereas they've shown that certainly if you're getting up into the 2s, you're very likely to be in DKA. So I guess the beauty of urine dipsticks is that people can monitor at home, but in the clinic, particularly if you've got a sick cat, it can be quite nice to actually get a number to trend downwards. So I do quite like blood ketones if I'm able to get them.
Okay, could you go over the reason why it makes DKA more likely, please?
Yeah, absolutely. So some of it is more just that Senvelga or belogliflozin will uncover cats that aren't producing much insulin at all, rather than just the cats that are insulin resistant. So when you give insulin, obviously it doesn't matter whether or not they're producing some insulin themselves. But if you give a cat that actually has already gone into that sort of absolute insulin deficiency state, a drug that isn't improving their, trying to treat diabetes without actually supplementing that insulin, they're going to develop DKA because they don't have any insulin themselves. But the reason it tends to happen quite quickly afterwards is, as I say, that it can kind of shift the body in a direction that makes you more prone to developing ketosis. So actually, by wasting carbohydrates, the body gets in a slightly sort of kind of catabolic starvation state. Whilst, as I say, we don't see a significant dramatic increase in polyuria and polydipsia, we do think these patients have some degree of volume depletion. So if you have a cat that can't produce much endogenous insulin, is going into a catabolic state, so producing more ketone bodies, and then is also subclinically dehydrated, that will just be enough to knock them off their perch. So that's why we think you have to be so careful in these ones that are even showing signs of developing ketones.
Can we monitor the ketones just using a urine dipstick?
Yep, so that's how Boehringer have designed their monitoring flow chart. So I'll see if I can just bring that back up. Sorry for the kind of going backwards and forwards, but I'll just bring this up for you. This is all available on their website. So you can definitely access that. We can get back to that. So it's a really nice sort of simply designed way of assessing things. I come back to it here. So it's just because we know blood ketometers aren't available everywhere, and once we have one, it often gives walkabouts. So that's why they've specifically said to use urine so that it's easy for everyone to do. Also, because if we are going to be wanting tend to even daily monitoring for some of our patients we're more worried about. We're going to be much more able to do that if people can just check urine dipsticks every day at home. The one slight caveat I'd say to that is that this was really driven by that American study. And it turns out that American cats are much, much more likely to be indoors. So apparently it was super easy for every carer to get urine, whereas I know that we definitely have some cats that just won't urinate in a litter tray. Then I guess maybe they're the ones where you would actually have to consider using blood ketone monitoring and maybe getting them in every 3 days in those first couple of weeks.
Okay, can you transfer a patient on from Prozinc to Zynvelgo? In patients with DKA, is there any that can be given alongside the Zynvelgo to reduce ketones?
So, in the UK, yes, we can transition insulin pre-treated cats to Zynvelgo. What Boehringer say is that ideally, if a cat is being well managed with insulin, don't rock the boat, just carry on. But what we would tend to say is to miss the evening dose of insulin and to give Zynvelgo the next day. At the moment, we would say if a patient is in DKA, just to not touch them with Zynvelgo because of the fact that it could potentially worsen it through the glucosuria and the catabolic state. Obviously, if the patient's already got it on board, then you can still, say they come in with euglycemic DKA as a result, we would still recommend starting them on an intravenous insulin protocol at that point, even when they have euglycemia, because obviously what we have to try and do is to stop the production of ketones. So I'm sure a lot of you, particularly working in emergency clinics, will have your chart as to what the blood glucose is and what rate of insulin infusion you use. You're essentially just starting right down at the bottom because they're already euglycemic, but they still have an insulin requirement. So I don't know if that was quite what you were asking, but yes, definitely avoid Zynvelgo in an active DKA. In theory, avoid it in any cat that's ever had DKA, although yes, if I did have a patient that had had DKA once and we were at the point where the carer said, look, I can't do insulin, I'm just going to stop and put the cat to sleep, I would still go ahead and use it just in case. But that's very much off the record.
Okay, how reliable is fructosamine in cats? Is there a difference in how reliable it is in between species?
Oh, that is a really good question. I actually don't know about the species related differences. As far as I'm aware, other than the issues with fructosamine itself and having to use very much kind of the individualized reference ranges and knowing that it's a very crude measuring tool. I'm not necessarily where it's better in cats versus, or more reliable in cats versus dogs, with the caveat that hypothyroidism in cats can really mess things up. And also, if you've got a patient that has abnormal albumin levels, particularly a patient that's got low albumin, that's going to artificially lower your fructosamine. Again, I would say I find it more useful to trend in an individual patient because every patient is going to be different in their rate of turnover of albumin and glycated albumin. So if you've got two cats with slightly different fructosamines, doesn't mean one is necessarily much better controlled than the other. But monitoring it, using it to monitor over time, I've tended to use it more traditionally in patients that have been difficult to get any other form of monitoring in. As I say, with Zynvelgo now having this flatline glucose and average glucose is actually quite informative. Whereas if you've got a patient that's swinging up and down, just drawing a line through the middle with an average blood glucose isn't necessarily going to tell you a huge amount.
What's your opinion on tailoring insulin dose to glucose reading every dose? I've inherited a case like this and finding it challenging.
100%, and I feel for you, especially if someone has gotten into a habit of it. How do you break that? And I'd say it's both good and bad. There's been a very recent study from an Australian cat clinic where they use glargine because they always use it there, and they aimed for really tight glucose control, so say between 6 and 12, which makes me a bit nervous that a lot of cats could become hypoglycemic. And they gave the carers a starting dose and then said, got them to do blood glucose monitoring at home and said, if the glucose is above X, give an extra half a unit. If it's below, give half a unit less. And they did get nearly 50% of their cats into remission. So I suppose in a way, if you're using it alongside home blood glucose monitoring, it can be of benefit. But I think also, particularly in the early stages where you're trying to work out what's going on with the patient, if you're constantly giving different insulin doses, it can be really hard to see the trends. So think sometimes people feel empowered to have that. And I guess the whole point is we want carers to buy into this because they've got to invest emotionally and financially in this. But what I sometimes do, particularly if you're able to use it alongside interstitial glucose monitoring, which is going to be probably the time it's most useful, is I'd perhaps say to people, look, we're going to start out with this shifting scale, and then I'm going to decide which doses look best and go from there. So I guess from an academic perspective, in theory, if you can kind of get people on board, having a shifting insulin dose to match your glucose is more reflective of how the body would work as a whole. But it can really complicate your management. So if you can try and persuade them to just have maybe a two-tier system, if it's above this, give that, otherwise give lower. That might be easier. But yeah, these cases can be a real nightmare.
I have a case which is not responding to insulin. On 2.5 units, Prozinc has clinical signs of diabetes, but also with low blood glucose on the Freestyle Libre. Can I switch to Zenvelgo? Otherwise, wow.
Oh, good one. And I guess the first thing I would say is we just have to make sure we've not got anything that's masquerading as diabetes. So if we've actually got low glucose consistently, if you've got a freestyle and it's not just low at some points and high at others, then it's not going to be the glucose that's causing the PPD and the weight loss. If you've got a low glucose at times and then really high glucose at others, yes, those periods of high glucose could cause the clinical signs. So then probably what we need to do is actually think of maybe using an insulin that lasts for longer, but at a slightly lower dose. So rather than having these big peaks and troughs, we try and even things out. So depending on the nuances of those freestyle readings, that sounds like a cat I may consider switching to glargine just to get, say, a smoother curve. Otherwise, if they're an otherwise happy cat, Zenvelgo in theory could be an option for them.
With the Freestyle Libre, we seem to get a lot of clients ringing overnight, worried about hypoglycemia based off individual glucose readings. How accurate is this generally?
We get this too. And this is where these are the 20% of clients I say where it just generates more anxiety. So definitely it's not, let's say, a perfect match with blood glucose. In my experience, the Libre tends to read 1 to 2 millimoles per litre below blood glucose. Probably kind of a safety reading from a human perspective. You'd rather read under than over. And so I guess there are a few ways that you can try and reduce this happening. It is very hard once people get into the habit. But I let them know firstly that it's probably an underestimate. The patient probably isn't as low as they seem. Secondly, that if the patient is still well, it's not technically emergency. So letting them know to feed and then check again in an hour, and only really to get too worried if they're starting to show clinical signs. And also if you've got a patient that's always been high and then suddenly goes low and is just reading low, 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 probably one of the first things I troubleshoot is whether actually it's become dislodged. So I've had some like that where I thought they've been beautifully controlled and suddenly we get this horrible hypoglycemic event occur and it's actually not at all. If they are a really invested carer, such that they're checking their patient's glucose at 2 a.m., maybe they're the sort of person you might be able to train to do the odd spot blood glucose. They might not want to do it all the time, but if you can maybe empower them to take a glucose reading at that point and demonstrate whether or not it's relevant, that can also help. But my key thing would be saying to them it's generally an underestimate. And so anytime you're starting a client with a Freestyle Libre, just to let them know that you are looking at the trends, it's not going to give them perfect numbers. Because if you don't start out like that and have to try and get them into that mindset, it's really hard.
Okay. Can cats go into a diabetic remission on Zenvelgo? Is there any data regarding the rate of diabetic remission with Zenvelgo use?
Sadly not. And this is a big topic of conversation because the studies weren't designed to look at that and they were only relatively short term. So they didn't have any cats that they ended up trying off the medication. So diabetic remission, and again, I apologize we didn't get around to this. You in theory need to be off medication for 4 weeks and maintaining a normoglycemia to be called to be in remission. So they didn't do that in any of the studies. So we just don't know. I guess, the issue again is that we've got a patient where we're artificially lowering their glucose and we're causing glucosuria. So it's going to be hard for us to be completely aware. But I suppose if you've got a patient that seems really settled, really well controlled for months on end, maybe even does, if you test them, have these occasional times of hypoglycemia or a lower fructosamine, it's probably worth tentatively trying them off the Zenvelgo, maybe then checking their glucose a week or two later, a week later. We think, you want to wait at least 2 or 3 days. But yeah, they very much say, the people that run the studies, that that's something they're going to have to look into because we have zero data for now. So I think we're going to have to be a bit creative, and I would probably treat a cat for a minimum of 6 months just to really reverse all that glucose toxicity. But then, yeah, it's probably going to be a case of just trying and seeing. But I wouldn't be surprised if more data comes out in the next year or so where they actually try it.
I have a cat who was diagnosed diabetic around a year ago, but the owner has been unable to dose insulin, so has been remained untreated other than diabetic food. He is obviously PUPD, eats well, and his weight remains pretty stable, and he is amazingly happy. He does have a neuropathy. Could he be suitable to start on Selvelgo even at this late stage?
Yeah, I think he'd sound like a pretty much perfect candidate if he's still happy. I mean, that is amazing. And it does just show the power of diet, and maybe he's more that sort of pre-diabetic state. But particularly in terms of maybe improving his neuropathy and stopping him from getting to a point where he does need insulin, which even if he's just got a little bit of hyperglycemia over time, we could tip into that in the future. I think this would be a really good idea. One of my sort of pie in the sky ideas, and not yet because we need to use Zenvelgo as per license for now to just get more of a feeling as to how it works, but is that maybe this could be a great drug to use for patients that aren't yet diabetic, that are really at risk. So say you're a big fat male cat that you need to immunosuppress for some reason, putting them on that at the same time. And people they use very early on before you truly reach a diabetic state. So yeah, I think that could be a really interesting candidate for Zenvelgo. Lovely. Yes. So I have quite a few sides, as I say, clearly big fan of just chatting about diabetes. So I do apologize for taking up that much of your time. So I'll just see whether there are any particular I wanted to go through. Guess we can flick back through very quickly. It's not all about the numbers, and particularly for people where monitoring isn't so much of an issue, or where we think we're getting discordant results because of stress or such. Looking at the clinical signs is really just as important. I think this is the art behind the science. So this is something I do for pretty much all of my diabetic patients at every visit. You probably do something similar without knowing it, just by asking a history, but this was produced by the Royal Veterinary College, and it aims to sort of put an objective score to all of the subjective aspects of diabetic management. So the key aspects being weight loss, PPD, appetite, and activity. Because ultimately, if we've got a patient like the one we just mentioned that seems super happy, is not losing weight, and may have variable PUPD, but is otherwise well, yes, it would be lovely if we could have glucose numbers exactly as we want them. But if our main aim is to improve our patient's quality of life, I'm not going to make decisions about their insulin just based on a number, their blood glucose curve maybe being a little bit higher than I'd like, if actually they look like they're tolerating things really well at home. Both because I think patients are very individual in how they tolerate certain levels of hyperglycemia or not. And also because, as we say, these readings often aren't sort of, cut and paste day to day. We can have a bad day or a good day. So this would be something I'd really try and get people to use. Even if you don't always have time to do this, I'd say it's really important for every diabetic cat, every time you see them, to document their weight, because I'm going to make, for example, a much different decision if we've got a diabetic whose weight is deteriorating versus one whose weight is going up or staying steady. So I'd say that's really key. And troubleshooting, again, I won't go into this in great detail because, again, there's so much to talk about. This is my friend Chris from my internship, I'm sure wouldn't mind me saying that he hates diabetes as well. But these are, I guess, the few key things I run through in my head for every patient where they're not doing what I expect. So firstly, is there a management issue? This could be related to food. What times are they eating? Are they snacking? What diet are they eating? Exercise is a bit more variable in cats. And then particularly their dosing regime, the time, whether it's consistent every day, how it relates to feeding, if they are sort of, mealtime feeders rather than ad lib, how they're giving it, even in a client that's been giving insulin for ages, especially if you're meeting for the first time, I often think it's worth getting them to show you how they draw up and administer the insulin, because sometimes people can really surprise you. I had a consultant pediatrician who kept drawing up the wrong insulin dose, so you can't assume whether they're using a syringe or pen and whether it's the same person every time, or whether we've got different family members injecting. In terms of the insulin itself, having it stored in the fridge, also how people handle it. So I think we always used to be told, you cannot shake insulin at all. Actually, with can insulin, you should shake it to resuspend the insulin, whereas with Prozinc, it's about rolling it more gently. Checking it's not running out of date. That's particularly important for our little patients on tiny doses. For some patients, they're never going to kind of get to the end of the bottle. They're never going to get to the end of the sell by date before they run out of the bottle. And again, with that cat we were talking about, with the kind of peaks and troughs potentially of glucose, trying to work out if the patient's on lente insulin or can insulin versus Prozinc, and rotating the insulin injection site as well, because we can get patients getting quite a fibrous buildup, which reduces insulin absorption. And then finally, patient issues. So do they have comorbidities that are either causing resistance, or, as we just said, kind of a masking and giving signs like the diabetes is poorly controlled when it may not be. And just being aware that there is individual response. So whilst it's a dog, I have one canine patient who I lost track of for a couple of years, and she is incredibly insulin resistant. She has had a glucose level of about 28 millimoles per litre for 2 years consistently, and has never gone into ketosis. Clearly, she just needs a very tiny amount of insulin to keep that ticking over, and not to control her glucose levels. So every patient is very different. I think these glucose curves we're quite used to. I can always run through that later on. But say, just to briefly talk about remission, as we said, normoglycemia without medical therapy for at least a month. And we've got some positive and negative predictive factors here. So the less time you've been diabetic for, the more likely you are to go into remission. The stricter we are with glycemic control, so like that Australian study, keeping them really tightly controlled, which can be a bit nerve-wracking, but does get better results. Sadly, glargine, which is kind of outside of the cascade, but where it does end up being better for cats. If they've got something reversible, like having prior steroids, they're more likely to go into remission. And weirdly, older cats, and this is the same in people as well, if you develop diabetes when you're older, you're potentially more likely to go into remission. And we're not sure if that means that you've managed to stave it off so long because you're otherwise in good health, or as a cat have a really sort of invested carer. By the way, older cats are more likely, but certainly signs like diabetic neuropathy or hypercholesterolemia, which are signs of chronicity, and also high fat levels in the blood, have a really toxic impact on beta cells, perhaps even more so than glucose. Really reduces your likelihood of going into remission. But even if they do, we have to be aware they're always considered pre-diabetic, and they have about 30% chance of relapse, much less likely to go into remission the second time. So really key, always continue dietary therapy lifelong. And my take-home messages would be that we can really try and intervene early with these patients to reduce their glucose toxicity, reduce their obesity levels and inflammation. That Velaflozin has been for happy cats, but I think we're going to see it being used for many more patients in the future. Interstitial glucose monitoring is great for guidance, but don't take it as gospel. We've got that mixture of the art and the science, just what you can see, and from the carer can give you as much information as otherwise. And remission is achievable if we can act early. And then last QR code is just, this is a list of references, in case anyone wants to look back at all of those slides and see where I got the information from. And I'm really grateful you've given up so much time on a Wednesday night to listen to me ramble on about diabetes. So we've already gone through some questions, but if you do have any other questions, just got some contact details here. So there's the community engagement team, any feedback on more generic questions. If you do have a really tricky diabetic case, our medicine inbox, you're welcome to email us.